This is United Medical ACO weekly event, and my name is Kemal Erkan. I'm the chairman of United Medical ACO. All right, good afternoon, everyone. Today is June 25th. It's a Friday. Well, happy Friday. We are going to go through our regular items again as we do this on a regular basis. So we have different topics that we are going to discuss. So I'm going to actually start sharing my PowerPoint presentation we prepped, and Tanner is going to join me after. So today we are going to discuss COVID-19 numbers with the vaccination, and then what's in the news and the Delaware legislative updates. We are going to give you some updates from these. As everyone knows by now, United Medical is a healthcare service provider, and we provide services from every level. Any practice that's out there from the, if they are independent practices, we are providing services for those. And we are not only providing services, we are also advocating for those practices. Now, Tanner is going to start with the vaccine updates.
Mm-hmm. Sure. Yeah, thanks, Kemal. We want to touch on some of our regular updates, particularly looking at the vaccination rate as is for percent of a population covered here locally in the state of Delaware. So you can see Delaware is reaching that 55% mark of the population that's being covered. Now, what we say by mean population being covered is the amount of people who have received their complete vaccination, whether it be some of that one dose for, say, the Johnson & Johnson one dose vaccine, as we know at this point, or the 2 doses of either Pfizer or Moderna. So in the United States, taking a look at the overall rate, we are continuing to slip downward just under that million mark now, which is actually increasing the amount of time or our pace to 75%, which is something we're definitely keeping an eye on as we move into the summer months and have been since the early spring, late winter. As you know, when we did start the vaccination rate, you can see there at the peak, we were close to 4 million a day, which had us on pace to being to 75% of the population covered at this point, which is why this is so important to keep track of. The lower the vaccination rate, the longer it's going to take us to get to the herd immunity mark. So as a whole in the United States, we're just now over 50% of the population who is covered. So it does seem like we're going to miss the mark, that federal Biden administration goal of at least 70% by the time we got to the 4th holiday, which is, as we all know, next week. And we're just hovering around the 50% mark. So what that does, the benefit here, though, that we are keeping track of is it has suppressed case rates, but we, of course, don't want to take that as everything is fine and we're okay there with the risk of COVID. Of course, the vaccinations are going to be the key to making sure the transmission stays low. But of course, we still want to err on the side of caution. We'll get into a particular reason why that would be the case here in just a second.
So from the, before we go to the variants, actually,
right.
Tanner, I do want to actually share the vaccination numbers. So,
sure.
So last week, you weren't there, I believe, right? So I actually started including from our providers meeting what we have. So I'm going to actually start showing that, and then it's an interactive data.
Okay.
So actually see. And I deliberately didn't check the last couple of days for the number from Turkey because they do so many of them. So I just want to see how that actually changed the overall numbers. So let me actually share this with you guys. So here's what you see is, and these are the number of people being vaccinated. So like we can actually change this. Like to the fully vaccinated, just the vaccine. So, and this is the total in the world number. So when I click on United States, we are going to be much higher than the world average, right there. So then I included Europe, and then now what I'm anticipating, and I assume that our people, our audience is trusting us by now. So I didn't check this, so that I just want to see how close we were going to get to Europe number from the Turkey side. There. So this is what I was expecting, because they are doing about 1.5 million doses, and now they're down to age 18. And if we were to go to, let's say, last week, what was today's 25th? That was 18.
Correct.
When we presented this, Turkey was at 31%. Now they're at.
It looks like at this rate, Kemal, they could easily pass that European average by next week, next time we are discussing this.
Down to age 18 now. So they started a little bit late, but like you can tell from here, like how steep this one is. So that's really, they're doing very good. So I'm a little bit worried about what our number is here. So because we were doing so well, and then now we are at the what's this percentage here? 50.
Just over 50. Now, yeah, it's a little worrying to see that really plateau now.
The reason we are worried about this is because you were going to explain us, just to kind of briefly tell us what the variant is and what is happening in the world, and then why we are worried about the Delta variant more than the others.
Yeah, so as we know, we've been keeping track of a handful of different variants to the COVID-19 virus. As time has gone on, of course, it's found ways to mutate into different variants. Particularly, there are plenty of different variants of the virus, as really comes with any type of virus. We see this with the common flu every year. Now, this is just something else to keep an eye on now as we do progress, and as the longer and longer COVID is being transmitted, it's going to mutate. It's going to there will be more types of variants that are detected. So some of the more transmissible ones, some of the more dangerous ones that we have been keeping an eye on throughout the course of the pandemic, we know were some of the ones that were being coming out of the United Kingdom, out of South Africa, Brazil, and even some here that were first identified in the United States, in California and New York. But now we're starting to keep an eye on this new, or this most recently detected variant, this Delta variant, that was first detected in the United States actually back in March. Now, it was initially identified in India. And if you remember a handful of sessions ago, at this point, it's been a few months, India was really dealing with a rough outbreak of numerous different COVID variants all at once that were really putting a strain on some of their existing logistical supplies for vaccine distribution, and even on their hospital systems as well. Really led to an increase in hospitalizations and some deaths in some cases. So now this Delta variant is something that we're keeping an eye on, particularly because it's been in the news recently. You may have seen that a lot of people are starting to suggest that this could be the next, one of the more common strains of the virus that we're going to start seeing here in the near future, especially over the next couple of weeks, if not, or months, if not weeks. Come on, you're muted.
Because I never mute. So then when I mute, I forget. So what's interesting here is the prediction and what we are able to predict. And when those predictions are happening, and some people are being kind of like, some people are surprised by this versus, well, we knew this was happening. So when we first presented this, in the United States, the percentage of the Delta variant was 5%. And now I believe it's 20%.
It's correct. Yeah, it's closer to 20% now of all cases.
I mean, what's the prediction for the next couple of weeks? Do you have any idea?
So, well, that is that's definitely going to be something to keep an eye on. I'm not sure exactly where some of the leading health experts really have that. Although, like as you mentioned, we're at 20% of cases now. They're definitely expecting it to become the dominant variant here in the United States, like I mentioned, in the next few weeks. So we're starting to see that in certain places. I have here, California is an interesting case right now. Because although they are one of the states that are leading the country in percent of people that are vaccinated and with their vaccination rates, they're seeing outbreaks of this Delta variant, which is why it's so concerning. And I think that as we learn more, you can see here, some of the things that are, of course, key concerns are what exactly does this mean as a new variant? Is this more infectious? Is it more deadly? And that very well could be the reason why we're seeing it in a state like California, who has a high percentage of people who are vaccinated, see an outbreak like this amongst their unvaccinated population. It definitely has an increase in transmissibility, which is of high concern.
So our next update is coming from this drug called Aduhelm, right?
Albuterol? I'm not 100% sure. I don't know if I've said it right yet.
Well, although I have the surgeon scrub on, I'm not a physician. I should have said that in the beginning, but many people know that already. So I don't want people to say that, oh, he can pronounce the drugs. It's because I'm not a real doctor. Let's say. So this is the drug that we are talking about. So Aduhelm, right? So
yes.
Now, in the reason we actually have in one article, it actually names as aducanumab or aduku. Okay, let's try aducanumab. Okay, that's exactly how it is. But this is different now. So I think the labeling is different, maybe. So this is an Alzheimer drug. People are dealing with the Alzheimer, especially in their late ages, over 70, 75, 80. So, like this is why we want to discuss this. Obviously, this is a United Medical Accountable Care Organization live session. So this is important for us because every time there are unexpected expenses added to the mix of treating disease, then this is affecting our benchmarks, and it's also something that we need to consider. Now, Tanner, I think you and I don't know if we talked about this before, but I'm going to give you some statistics. And now you know these,
sure.
but sometimes because until we really look at these, we don't know exactly how the situation is. So if you look at the elderly in the United Medical population, when I say elderly in the Medicare population, so I'll give you like one example. So I'm going to try to remember this properly. So in the beginning of the ACO, this is 2016. So we wanted to do different things, and because the age 65 and over. So actually, Donna Grankular, one of our directors on clinical integration, she and I, we were going through some stuff to see what we can do to reach out to the patients, what we can do differently for the patients. And I said, you know what, let's run the patients who are over 85 and over, and then let's see if we can actually help them with the home environments, and maybe they may have some stuff that we can help them with the fall preventions. And the reason I picked 85 is because I was thinking, so we have like 12,000 members, and I was thinking that with the 85 and over, we would have like maybe 100 patients. So, well, I was very wrong. It was more than 30%, I believe, was over 85. In fact, one of our patients was 95, and some of her blood work results was better than mine. So she didn't need anything, right? So now why we are saying this is because our population is aging. During this aging, we have Medicare in place. And when Medicare was set up originally, this was I think in the 1960s, our life expectancy wasn't this high. So therefore, what we are paying throughout our employment for Medicare is not what we are getting it's not enough for what we are getting as a service today because Medicare covers everything.
Right.
So now we pay for the service. Medicare is not free. We are paying for Medicare. So like you've been here for how many years now?
About 2 years.
2 years. So in 2 years, we paid Medicare taxes for you, Medicare fee, whatever you want to call that. Throughout your employment until you are 65, this is going to be paid. Now you are paying and then you are going to use it after you are 65. So then projection for how many people would be at certain level at certain time who would be utilizing these services was way different than the original numbers. What happened today versus what was projected is way off because people are living longer because we have better treatments, better care, therefore people live longer. But where we are failing is we didn't go back and make the proper adjustments on the pay structure throughout the employment for the Medicare. So therefore there's a huge gap. Medicare is one of the biggest budgets, has one of the biggest budgets, probably it's bigger than some of the countries in the world. So like Medicare's budget is bigger than some of the decent sized countries.
Right.
I don't, like I may be outdated with the number, but it's probably 700 bill, if I'm not mistaken. So it's huge.
That's an annual budget, right?
Yeah. So, but it's not enough because there's a huge gap, deficit in the budget. So therefore, when we have a drug, now why we are discussing this drug is not because there's a new drug that's going to help the patient. That's not the case. So this is actually, there's a controversy on this. This drug is approved by the FDA. However, FDA advisory board did not recommend it for the approval. That's kind of like, in healthcare, every once in a while, I still get surprised by these types of news because you would think that it wouldn't happen. So there's an advisory board and the entire board actually refused to approve this. So it does not recommend the approval.
Right. Yeah. That was something I knew I had certainly learned with this as well. It was kind of shocking to hear that the advisory board had, who is of course put in place to advise the FDA director, based on clinical studies, based on reviews of that clinical data, and coming from their own particular professional backgrounds when it comes to drug safety, statistic analysis, things like on that more clinical side. You can see here that they definitely did not recommend based on the studies. Now, what was interesting was there were 2 clinical studies that they were looking into to kind of make a decision on the approval of this drug, and one of which actually failed, which was pretty interesting. Now, the other one, not necessarily as conclusive on the evidence, and I think that that's of course why we're seeing so much confusion on this decision.
So this is interesting as well. So just like how expensive this drug is, one of the, so it's not approved, but it's also very expensive.
Very expensive. I believe.
I'm sorry, I'm going to rephrase that. I misspoke. It's not recommended by the advisory committee, but it's also extremely expensive, and FDA still went for it. And then here's like one figure here. So I'm going to zoom in for you guys a little bit.
I think it's, if I'm not mistaken, it's like, yeah, there it is, $56,000 a year per patient.
Yep.
Not including additional imaging and scanning that you would need to make sure this is actually appropriate.
So the Medicare spends about $90 billion on prescription drugs for 46 million people. Okay, so now where is the budget for this one? So here it is. So this can be service to those 6 million people, and then it can actually, the healthcare spending could swell by 112 billion annually. So that makes pretty good sense, right?
That's a lot of money.
So I think I get a warning from Anthony. Let's see. Um, oh, Anthony says it's still advisory, and there are previous times that FDA has declined to follow their recommendations. And Anthony, I'm good, thank you. And that's true. But in this case, the cost, I guess, is extremely high. And then because there is no budget for this, so that approval, the gap on the approval or the disagreements on the approval will have a very severe impact in the budgetal terms. So Anthony, if you want, I can bring you up. If you would like to be part of the discussion, you can use the link and then we can discuss more. But thank you for sending that. So this is pretty much what we do, what we have in hand. So we'll probably bring more updates on this one. And this site that I'm sharing, the Atlantic, is a little bit too much far on the right. And the same thing, though, we have it from New York Times. If you're a Democrat, you can just read the same thing from New York Times. So, but you have to have
today, the Biden administration announced their investment of $3.2 billion.
Hold on, guys. From the so the same news is actually on. If you want to go to New York Times and then from my Twitter, you can find it. And I think because I'm not signed in, so no, this is actually a different one. I'm sorry. Hold on a minute. I posted two different things. Yeah, there. Oh, yeah, it is New York Times, so I wasn't lying. I usually don't anyway, but so this is from New York Times. You can read it wherever you want it from. So I usually try to read it. I mean, if I watch a little bit CNN, I usually watch a little bit Fox News, so then I can have a proper idea of the issues. So, and then unfortunately with this one, it's the same. So there are different views on this issue. Now, let's go back to our presentation. Now, one of my good friends and our former Delaware governor, Jack Markell, is nominated to the U.S. ambassador post. So this is, he's appointed by President Biden. He is going to be the ambassador to the Organization for Economic Cooperation and Development, OECD. And he still needs to be confirmed by the Senate. I do want to take a moment and just congratulate Governor Markell. I worked in his transition committee in 2008. He did so much good services. He provided so much good services for Delaware in the 8 years of his term. Tanner, interestingly, my last domestic trip here in the United States was to Boston. It was, I think, December 2019. He was sitting next to me, and then we talked for a while about what he was doing after, because he's a very young guy for someone at his age with his experience. I was expecting him to be I was expecting him to be the running partner for one of the presidents, but I'm glad that he's back to do more, and he's an excellent person. Want to congratulate him.
That's good to hear.
So now we discuss a lot of news and a lot of healthcare problems, healthcare cost-related issues, healthcare quality issues. And while we were doing this, our state auditor, Mrs. McGenius, right? So she was able to identify 24.5 million overpayment for the past 3 years for the pharmacy benefits. So we want to actually share this one with you. So this was in the news. Now, this is really important for us because why this is important. So this overpayment, so Tanner, I have some news for you. So this overpayment does impact our ACO cost averages. So because there are these are for the people who benefit from the pharmacy as an employee of the state. But then who are they? They are the people, like some of whom are our patients. So if there's an overpayment that impacted. So actually, Anthony, since you are listening at the session, perhaps we can try to understand the impact of this 24.5 million on our numbers. And if it wasn't because of this, perhaps we could have made more shared savings for the insurances that we work with. So I'll wait for Anthony for a couple minutes if he wants to join. But this is, so the, Tanner, I just want to explain this to you a little bit more.
Sure. Yeah, actually, I was going to ask, because this is one of the things we didn't have a chance to really discuss or go over prior. So
apparently what happens is, as you know, like there's a medical insurance part of it, but every medical insurance, it comes with the pharmacy benefit. Now that benefit doesn't have to be part of the medical insurance. Like we may have, let's say Blue Cross, and then our pharmacy may be running by someone else. Patient may have, let's say Aetna, and then their pharmacy benefit is from a different place. So these are the third-party administrators that I've been talking about. Third-party administrators are just like any other insurance companies. Like, I can help sometimes just but ask these questions like almost in a quiz format. So what's the breakdown of the TPA business of Blue Cross? If I ask this question to Tanner, he'll answer right away, right? So
correct. Yeah, we had a whole session on it. It was about 75%, right?
Exactly. So 75% of all the insurances, their business is TPA. Now, this pharmacy benefit is through the TPAs, and Anthony is joining us. So right now, I'll admit.
Bring it in. Might just taking a second to get connected. Hey, Anthony. Anthony, can you hear us?
I think he's connecting still. So,
yeah.
Hey, Anthony.
Yeah, hi, Kemal. I'm good. Well, the good news, if there's any such thing, if the good news about this is that this is coming from Express Scripts. Can you hear me?
Yes.
Yeah.
This is coming from Express Scripts, and this is largely oops. Hi.
Yeah, we are able to hear you, Anthony. Anthony, we are able to hear you.
Okay. As I mentioned, it's coming from Express Scripts, and this has to do more with the state's benefits plan than it has to do with our value-based contract.
But wouldn't that be if we have a high mark, wouldn't that be part of the medical cost for the high mark because the pharmacy benefits are part of that?
It wouldn't directly spill over to our cost and utilization numbers on the true performance side. It would not.
So I was hoping that it would.
Yeah.
Okay. So that's but the reason we want to discuss this is because just this what I circled here, Delawareans spend more money than was necessary. So with this pharmacy benefit manager, so this PBM, it's like the same.
Yeah, I think that indirectly it could impact it because what it does is that it sets a different payment standard across the board.
Mm-hmm. So it may be affecting other plans, this is from the state side of it, but if this is a common practice, even the one that we are contracted with, it may not be part of this 24 million, but there may be another 24 million pot that wasn't discovered because the state auditor is just looking for the state expenses, right? Anthony?
Did we lose him?
I think he's having some connection, not the connection issue, but his headphone is having an issue. Anthony, are you able to, and then we lost him. Okay, so he'll probably come back. So what we are trying to say here is the increase 3 times more than the national increases. So that's a huge expense item. So just to see what PBM is, just to easy, like, Tanner, I want you to remember this next time I have the quiz. So PBB is a TPA. So in the pharmacy world, same thing. It's hired by employers to manage prescription drug plans and then expected to contain cost by negotiated rates for prescription drugs and drug makers and pharmacies. And we actually, I talked to John Donnelly regarding this. He's the one who actually brought this up to me earlier this week. And one of the big problems with this one was we knew the discrepancies between different pharmacies. Some of the pharmacies have a different fee schedule than the others. So this does definitely impact what we are doing, but hopefully this would be a good way to bring this to everyone else's attention. Now, we do want to thank Kathy McGunius. Is it McGunius or Junius? What's her last name?
McGinnis, I believe.
McGinnis. Did we invite her to our session?
We did. I believe we reached out to, and I would have to talk with Anthony again. There was someone from the office who was going to be available to speak with us.
We want to talk to her. We don't want someone else.
Okay. Well, yeah, what we can do is we'll certainly reach back out. I'm sure she would be more than happy to come on and discuss this with us.
I mean, this is a great platform for her, right? So
sure. Yeah.
We'll get more views than the Delaware Today, or no, Delaware News Journal. But this is really interesting how expensive things become, and then this is why we have to kind of keep these things in front of everyone. The transparency have to be there. But, so this is, you see this one here, as of July 1st, 2021, CVS Caremark will become the PBB for state employees. So now anyone who's using that will be impacted. The providers will be impacted by this.
Yes.
So I think Dr. Hosmani is also sharing this. He's one of the people who shared this news with me as well. So if we can reach out to Kathy and invite her over, and then maybe we can discuss a little bit more.
Okay. Yeah, no, that sounds good.
All right. So now, Tanner, talk to me about our next guest who's going to be part of the That's next week?
That is next week. And I did kind of want to lead into kind of what we would be discussing next week. And it started with some other news, legislative news that came out in the state of Delaware. Now, this was kind of in the making for a handful of months now. But Senator Sarah McBride had introduced a paid family and medical leave legislation. And what this essentially was going to do was to guarantee a certain amount of paid medical and family leave, of course, here in the state of Delaware. Now, just doing some initial reading, it seems like that this is a sort of a personal thing, or comes from a personal story and issue for the senator. So it's something that's close to her and that she's been working pretty hard on for the past year or so. And just kind of like some quick little tips down here for what exactly that.
You said this is kind of personal for her. Are you saying that from the personal view?
Well,
what do you mean by
that? Yeah, no, that's a good question. From what I was reading, the reason she's championing the bill was she actually had a family member who had cancer, and she needed to be out of work for extended or for periods of time where she needed to be available to kind of help with some of the treatment that she and her family were going through during that time. So that was really the reason why I think she wanted to start and kind of have some sort of initiative pushed through legislatively here in the state. So as Kemal did mention, kind of spoiled my surprise a little bit as I was getting into down here. She will be the guest next week.
I wasn't planning to do, but I think it did.
No, that's all right. That's all right. I was going to kind of ease into it, make it a fun introduction here at the end. But she will be on next week to kind of have that conversation, what that means for the state of Delaware, what the goal and the vision is exactly with this new legislative initiative. And just a little bit about her. She is the state senator here in Delaware, representing Claymont, Bellefonte, and some parts of Edgemoor and Wilmington. So she's from Delaware, and she will be joining us next week to have that discussion. Now, there was just a quick a little bit more about the guest. And this was something Anthony had actually brought up and included for our providers last night, was that she was actually, or is actually, one of the co-sponsors of the telemedicine House bill or state Senate bill, excuse me, that is going to kind of relax and kind of make permanent some of those flexibilities we saw with the onset of the pandemic, and then having telemedicine be, there's no in-person requirement, I believe was one of them, for a patient to have received telemedicine care. They don't need to be seen in the office first before they can do that. And then some of the others were, I believe, in regards to making sure patients are available for relaxing some of the, or maintaining some of the flexibilities with the audio only visits as well. So she was in part with Senator Townsend and Representative David Bentz, who we've both had on. She's helping push some of those healthcare initiatives as well here in the state.
And is she the first transgender Senate member?
Correct. Yeah. So she's not only here in the state of Delaware. Actually, she was the first openly transgender state senator in the United States.
There's no openly transgender; it's just transgender.
Well, she was the first one to take on the role.
And that's really interesting that Delaware would be. So we are very accepting, welcoming, and in Delaware, in a small state, we are able to demonstrate so many good qualities. And I think accepting everyone the way they are is one of our good qualities. And I'm actually proud of the way that it is for us to have someone like her on our side and also working with our healthcare issues. So this is great. So I would love to chat with her more about what she's doing on behalf of the Delawareans and also for the healthcare providers.
Certainly.
All right, so Tanner, we have, I believe we are almost at the end, right? So just so that we remind everyone that we have all of our sessions are available on our YouTube channel. And then, and hopefully more people are watching it. Now, since we have a couple more minutes, I do want to bring one more issue up.
Sure.
This is our personal issue, not personal issue, obviously. This is our issue that we take it personally, Dr. Erkan and I, what's happening in Tigray. And just recently, there was an airstrike, and I think 52 people died. So my biggest problem with these types of issues is that, we are watching this to happen and then just get to a point where it's so unbearable and then we are going to intervene. Isn't that too late? right? So if we get to the, when we get to that point, that's already, like there are 6 million people in Tigray. So if after 4 million dies, is that when we are going to intervene? So this is actually, there was a Turkish channel actually published that. But I think it was on Twitter, but let's go with this. So this is happening right now as we are just doing everything just like nothing is happening. And this is happening in the world that we live in. So how much time, how much effort we have to save lives. So, and then actually this is the one that I find. So here I'm going to share this one from here. This is, oops, where did it go? I mean, this is not an easy watch.
33 people are still missing. The attack comes amid some of the fiercest fighting in the region since Ethiopian soldiers launched a crack.
I'm just going to play
More than 100 people are wounded and at least 33 people are still missing. The attack comes amid some of the fiercest fighting in the region since Ethiopian soldiers launched a crackdown in November. And earlier this month, the UN warned that 350,000 people in Tigray are at risk of famine. More than 100 people are wounded and at least 33 people are still missing.
Why I'm sharing this? Number one, we did 5 different sessions to discuss these issues, and we want everyone to be aware of what was happening. This started in November 2019, 2020, and today is June, and we still don't have any meaningful way of addressing this issue. Now, like I didn't have a chance to talk to you this morning, but right now, Dr. Erkan and I, we are in the middle of hiring a legal representative in Norway, and we'll be able to actually hire a lawyer to go after the Nobel Peace Prize Committee because they still didn't take any action. You cannot have you cannot label people with peace and let them kill people, and then after they start doing it, you are still not taking any action. That's not acceptable, and then we'll go after that. I get a lot of hate emails these days, hate messages. So those are from, obviously from Ethiopia. But we don't have any political views on this one. It's all about the people. Every life is important. So, and we don't really care if they can actually hate as much as they want. We have to tell the truth. So that's where we are right now. And hopefully we'll get some meaningful progress in the next couple of weeks. And then I'll be sharing those with you guys as well. Now we'll have our Bariatric Friday event at 1 p.m. Since we finished our all the sessions, so we are going to start we are going to start repeating them again, and then we'll be discussing that with the different, maybe different ways, hopefully. So we'll be back in 10 minutes. So thank you for watching us. Bye-bye.
Thanks, Kemal.